This lecture will cover Chapter 34, Mature Lymphoid Neoplasms. The mature lymphoid neoplasms are a diverse collection of diseases that have varying clinical presentations and histories. Now, typically, this disease is going to kind of present with more of a normal appearance within the blood, bone marrow, and lymph nodes. However, where the neoplastic transformation takes place is actually where you see some sort of abnormal change within the growth and differentiation patterns of these cells, and then that's what's going to actually result in the disease process. With leukemias, the primary site of the disease is actually going to take place within the blood and bone marrow, whereas your lymphomas, the disease will actually be localized to the lymph nodes and spleen. Now, one thing to note about your lymphomas is they may actually go through a leukomatic phase in which those malignant cells will actually be seen and present within the peripheral blood. Now, your plasma cell neoplasms will tend to have a bone marrow basis to them, but extramedullary involvement may be an important part of the clinical presentation of your plasma cell neoplasm. So that's going to be when you have involvement outside of the bone marrow. One of the many genetic abnormalities that will actually characterize the B-cell lymphomas involves an actual immunoglobulin gene. Now, these mutations in these individual genes can sometimes result in a defective gene with an altered product that has some sort of negative implication within the cell's overall growth and function. Now, alternatively, there can be chromosomal translocations that can actually cause your genes to become misplaced, and it can actually expose them to some sort of stimuli or suppression that will result in an altered expression of that pattern. Now, these alterations can actually cause the clinical disease presentation. Now, some examples of alterations would be the MCY or MYC, which actually stimulates entry into the cell cycle, BCL2, which suppresses apoptosis, and BCL6, which can suppress the transcription of other genes necessary for cell growth. So these mutations are often found in a number of the lymphomas. Your textbook does have a nice chart that kind of summarizes some of the common chromosomal translocations and the altered genes. You're not really expected to know all of these. Just know that if you're looking for a particular disease, then when you're looking and doing genetic testing and find these alterations for these chromosomes and genes, then that will indicate the particular neoplasm. Now, vast majority of your mature lymphoid neoplasms will actually represent a malignant transformation of the lymphoid cells at different stages of the development. So obviously, examination of the morphology of those cells is going to be your first step in interpreting the patterns of involvement. However, it is imperfect because different diseases can present with a similar appearance. This is where you actually use flow cytometry and immunohistochemistry as part of your methodologies to diagnose and differentiate these disorders. The ontogeny of your B, T, and natural killer cells is helpful when you're trying to understand some of the biological behaviors of the lymphoid neoplasm, and it also helps to form the basis for the classification of these disorders. Now, the World Health Organization has developed a classification system that is actually based off of a multi-parameter approach to the diagnosis. Now, there are a lot of these that are listed based off of these WHO classification. So your textbook does have a nice chart that kind of divides these up based off of their typical behavior and how they present. So you do have some that are a little bit more aggressive, and then you have some that are divided up to an indolent disease. So these are not as aggressive. They're more what you can consider lazy or slower progression to these particular neoplasms. So here's that 2016 World Health Organization classification for the matured lymphoid neoplasms, and like I mentioned, it is a lot. So I am not expecting you to know all of these. We're going to kind of go through some of the more common ones that you need to be able to recognize. Just take from all of this, when we talk about all of these different neoplasms, your role is not to make the diagnosis. Your role as an MLT will be to note when something is abnormal, when something is outside of the normal, what we consider a normal presentation for patients or a normal population. Once you detect that, you see that there's something that's abnormal, and your site will have criteria set that if the patient meets this specific criteria, for example, a white blood cell count above a certain value, then you would refer it to pathology for some sort of review so that they can further delineate what may be going on, whether it's just some sort of inflammatory response or whether it really is some sort of neoplasm. Now, the clinical signs and symptoms for these diseases that we're going to discuss can range anywhere from being asymptomatic and the disease actually being detected on just a routine CBC, or the illness can be characterized by more aggressive symptoms like fever, weight loss, night sweats, swollen glands throughout the body, and even some sort of functional compromise. And this is why doing a history and physical of the patient is important, so that the physician can kind of start correlating some of the presentation that the patient may have symptom-wise with laboratory results. So basically what the physician needs to do is be able to kind of narrow down if the patient is just having some sort of reactive condition because they have some sort of infection or inflammation, or whether there is some sort of neoplasm that could be present and that needs to be further diagnosed. Now, early on at the start of these disease processes, you can have some symptoms that can mimic other things. So some of those early symptoms can really kind of be put off or not really paid a lot of mind to, because you may suspect it being kind of related to something else, but in hindsight you kind of realize that, hey, this was part of this disease state presentation. So a CBC is going to be one of the first laboratory tests that will actually be ordered to investigate a patient's symptoms and of which there's some sort of quantitative abnormality that you may be seeing on that CBC. And so that's going to kind of give you an indication that there's something pathologically underlying that's causing that increase in those numbers. So we need to look into it. Now, the patient can actually present with a normal lymphocyte count or automated differential, or the machine may not flag any sort of morphological abnormal cells, but that does not mean that we can actually rule out the presence of those cells, because we kind of need to take a closer look at that peripheral blood. So if a physician is suspecting that a patient may have some sort of neoplasms, more specifically a lymphoid neoplasm, they are probably going to order a manual review of that peripheral blood smear. So even if the CBC analyzer does not detect any sort of abnormality, you still need to make that smear and look at those cells just to see if maybe they are kind of presenting with a little bit of an abnormal appearance. Now, if at any point any cells are seen that are abnormal or suspect, then it may prompt further diagnostic procedures like flow cytometry or doing biopsies of bone marrow or the lymph nodes. So doing the immunophenotyping is very helpful to kind of classify which disorder you may be dealing with. As you can see, most of these have in common the CD19 and the CD20 positive cells, but some of the other markers can help differentiate one from the other. So biochemical analysis can actually be helpful for a variety of reasons. It can help you to evaluate the organ systems for any sort of compromise due to that tumor involvement. It can indicate what sort of tumor burden that you actually have. It's like sort of like an indirect measurement of that tumor burden. And it can also help with determining prognosis. Now, if there's any kind of indication of some sort of organ involvement, then that could include doing additional testing like biopsies or imaging. So basically you're just looking for things of where there may be issues with other organs like the kidneys, looking at some of those kidney lab results, even down to like the liver. If there may be some sort of liver involvement, then you can see some of those liver enzymes with various issues there. Now, your anatomic pathology testing can include things like actually doing a biopsy of that suspected tumor in one of those organs, and that's kind of considered like the gold standard. But some, because of convenience and the ease of actually collecting the specimen, some facilities may actually do a fine needle aspiration. And of course, with coupling that with flow cytometry, FISH analysis, it can help with actually making the diagnosis of that disease and doing the screening processes to actually differentiate some of your different diseases. So your pathology testing can actually help with that. Now again, if there's suspected organ involvement, and of course you can have different imaging that can be done from x-rays to CT to MRIs, things like PET scans, where the PET scans actually put those tracers in the body to look for hot spots on the patient that would be suggestive of a need to do a biopsy of that particular organ system. Now, staging systems will actually incorporate the data from the clinical laboratory testing, the anatomic pathology analysis, radiology, and any other sort of physical exam findings. And then staging with those systems kind of helps with prognosis. So again, it's based off a scoring system that is assigned to various parameters, and then patients are categorized into one of 4 prognostic groups, which would include low risk, low intermediate risk, high intermediate risk, and high risk. Chronic lymphocytic leukemia is the most common leukemia in adults within the Western countries, and it's diagnosed at an annual rate of approximately 1.1% of all new cancer cases within the United States. Now, it is a disorder of the B cells, although previously it was thought to be a T cell variety, and that has since been reclassified. Now, it's generally a disease of older adults with a median age of diagnosis to be approximately 72 years of age, and it does have a predominance more in males than females. Now, most patients are asymptomatic when they are diagnosed. And it's often just detected by a routine CBC in which you will see a predominance of at least 5 times 10 to the 9th of the circulating B lymphocytes that have gone up that high and stayed that high for at least 3 months before you can actually make that diagnosis. Now, of course, with the more modern techniques, it can be confirmed by doing some flow cytometry. Now, morphologically, when you see these patients in the laboratory, they're going to present with about 85% or more of the lymphocytes that will have this classic appearance, where the cells will actually appear to be small and mature with a very scant cytoplasm and a very dense nucleus that has a very dense chromatin pattern. And this is often referred to as a cobblestone or a soccer ball type appearance. So you can see that down here in this image down here to the bottom where you've got these cells. I mean, they kind of look like normal lymphs. They're just that nucleus is a little bit more condensed than what you would typically see, but you can see that you barely have any of that cytoplasm. So using some of your morphological techniques on the microscope where you just kind of you tweak it a little bit with that fine focus to kind of go up and down just a little bit so that you can actually see a little bit of that edge to that cytoplasm. Now, prolymphocytes or atypical lymphoid cells can be seen, but they do represent less than 10%, or less than 15% of all of the circulating lymphocytes. So 10% for the prolymphocytes and 15% for the atypical cells. And you can see an example here in the second image where all of these cells they're more of that atypical shape. So they really don't look like variant atypical reactive lymphs that we call when we're looking at something like Epstein-Barr virus or mono. But they do have that very large shape to them. So that cytoplasm doesn't quite have that reactive lymph appearance to it. But these are kind of atypical prolymphocytic type looking cells. To make that prolymphocytic diagnosis, of course, it's going to be dependent on your site. Some sites will not call prolymphocytes, but you are looking for that nucleoli to be present to call those prolymphocytes. One of the most classic findings that you will associate with CLL is going to be the presence of what we call smudge cells. So because that cytoplasm is so fragile, when you actually push and make that smear, it causes that cytoplasm to rupture. So it'll leave behind a remnant of that nucleus. And sometimes you can actually see a remnant of the cytoplasm around the edge of it. Now, typically we can kind of know that these are lymphocytes. So some sites may actually have you call these as a lymphocyte. I'm a little bit hesitant to do that because you can have, it can skew your numbers some. So not calling them can skew your numbers because these probably are lymphocytes. However, if you do call them lymphocytes and they're not lymphocytes, then that could skew your numbers as well. So one thing that you can do to kind of help alleviate this problem is to mix a couple of drops of your patient's well-mixed whole blood sample with a couple of drops of albumin. Mix that up really well, let it sit for a couple of minutes, and then push your smears using that preparation that you made with that albumin. And that albumin actually helps with keeping that cellular morphology for those cells when you push that slide so that you can actually count them as lymphocytes. Now this can be further, this disorder, chronic lymphocytic leukemia, can be further divided into subtypes. You have a typical type that accounts for about 80% of the cases, and then you also have the atypical type that presents for about 20% of those patients. Now we're not going to kind of go into these in any sort of detail. Just know that when you see a patient that has that high lymphocytic count of those, what appears to be more of your normal lymphocytes or your even some of your prolymphocytes, that you do need to make a note of it, especially when you have those smudge cells present. So even if you're not quantitating those smudge cells, you do need to note that there's a marked number of smudge cells present on that slide. And then of course refer this for a pathology review. So in doing an immunophenotype, these CLL lymphocytes do present as with B cell markers CD19, CD20, and CD23, but they also co-express some T cell antigen CD5. Antigen expression is sometimes variable, so not all cases fit into the classic CLL immunophenotype profile. So in order to account for this variability and to be able to differentiate CLL from any other type of B-cell neoplasm, then a scoring system has been developed, and that scoring system is based off of several different factors. And then once you do that scoring system, then you're looking for scores of greater than or equal to 4 to be consistent with CLL. Low scores of 1 or 2 are suggestive of some other non-Hodgkin's lymphoma. And then an intermediate score of 3 can be problematic, and so cases like this may require a biopsy of a node or some sort of molecular data in order to be able to establish a diagnosis. Your uncomplicated cases, of course, are typically going to be able to be diagnosed based off of the findings of the peripheral blood smear. So seeing those smudge cells as well as that lymphocyte count and just those lymphocytes that have a very classic appearance could aid in that diagnosis. But an extensive workup that includes a cytogenetic panel, bone marrow biopsy, is often performed for patients that have symptoms in order to be able to determine what what sort of therapy may be needed. Myoclonal B-cell lymphocytosis and small cell lymphocytic lymphoma. So despite having a documented monoclonal B-cell population in the peripheral blood, some of your patients don't really meet the criteria to actually establish a diagnosis of CLL. So patients who are asymptomatic without any sort of lymphoadenopathy or any kind of organ swelling, cytopenias, or systemic symptoms with a B circulating B cell, B lymphocytic cell count that's less than 5 times 10 to the 9th, they are actually referred to as having a monoclonal B cell lymphocytosis. Now, these patients do have a risk to be able to progress to CLL. Now, other individuals with less than 5 times 10 to the 9th of circulating B lymphocytes and evidence of the disease elsewhere, such as adenopathy or enlarged organs, they are classified as having a small lymphocytic lymphoma. So the histological confirmations from a bone marrow biopsy is needed to actually confirm this disease or to identify this disease, but clinical management of small lymphocytic lymphoma is very similar to that of CLL. Prolymphocytic leukemia is a rare disorder that makes up about 1 to 2% of the lymphoid leukemias. It has a distinct clinical course that differs from other mature lymphoid neoplasms. It is a disease of the elderly with a median age of about 70 years of age, with an equal distribution between male and female. Although both T and B forms exist as separate disorders, they do share some of the same clinical features. It is largely an aggressive disorder, and the primary manifestations is going to be seen within the peripheral blood, bone marrow, and spleen. Clinical presentation is going to be characterized by a very enlarged spleen as well as a marked absolute lymphocytosis value of more than 100 times 10 to the 9th. Now, if you see a white blood cell count that just continues to rapidly rise, if let's just say the clinician is just kind of monitoring the patient, that rapid rise in that blood count and that CBC white blood cell count will actually be a clue that this is not CLL. So with this disorder, you're going to see those white blood cell counts to reach a very high level. Lymphoadenopathy is very minimum, but there is a high incident, particularly with the T cell subtypes, of a tissue involvement with the skin as the common area of infiltration. Now, morphologically, those B cell subtypes, which actually accounts for about 75% of the cases, those cells will be medium to large in size when they're compared to a normal lymphocyte. They're going to have a very large cytoplasm, a more open chromatin pattern, and you will actually see a prominent nucleus within that cell. Now, the T cell variety is, these cells tend to be smaller and the nucleus is a little less distinct, so it does make it a little bit harder to differentiate these particular cells because they can be very common to the same look that you can see in other mature T cell malignancies. Now, because of this, you would need to do some sort of immunophenotyping and genetic studies in order to make the differentiation and diagnosis. Now, one thing that you will see and encounter in the lab is that the prolymphocytes are morphologically different from normal lymphocytes. So your automation or your machines can very likely call these or flag these as being atypical or variant, or you could see something like a blast flag on your printout, or you can see a multiple or variety of these things. So if you get something like that, of course, doing a peripheral blood smear to review to see if you actually see any of those cells present or whether it's just a prolymphocyte is going to help you to be able to kind of differentiate what disorder you're dealing with. Now again, Some places may actually call prolymphocytes now, where some are not going to make that distinction, so they may actually refer to these as blasts. So you will need to follow whatever protocol that your site is using. Prolymphocytes is not a term that's really used very often. It is being referred to more now, but some of your texts that are from an older generation, if you use the term a prolymphocyte, they might look at you funny and not really know what you're talking about, because this isn't something that was really taught to them. So just be aware that prolymphocyte, it's terminology that you may or may not have other people familiar with. So you want to be sure to follow what your site says specifically. Hairy cell leukemia is an indolent disease of a B-cell lineage, most commonly found in the middle age, with a median age about 50 years old, and it's more seen in males than females. Mostly targets the spleen, blood, and bone marrow. Patients will typically present with an enlarged spleen, cytopenia. Characteristic hairy cells will actually have a round to ovid type nucleus. They will lack nucleoli, and they will have a relatively abundant cytoplasm with these ragged projections that will extend around that outside edge. You can see some of those here in these images. This cell right here is a really good one. You can see all those projections coming off those cells. Now occasionally, just from the push of the smear, you might see an occasional cell that will look something similar to this. So you need to make the classifications of those cells not just based off of seeing one or two cells, but you're going to have a predominance of those cells. There are some morphological variants that you can see, where those little hairs are a little less predominant than what you would typically see. So if you are ever in question of whether or not that you're looking at a hairy cell, of course you want to kind of go ahead and lean towards the safe side and do a pathology review, and then let them make that diagnosis or decision as to whether or not additional testing is needed. Now, when we're doing if a physician is to order a bone marrow for a patient that's suspected of having hairy cell leukemia, then that bone marrow collection can be very difficult because you can have a presence of marrow fibrosis. So ultimately, doing the histochemical stains for those CD markers, looking for an anti-CD20 antibody, is going to help with the diagnosis of this disorder. Large granular cell lymphocytic leukemia. So these are disorders that's going to affect older adults, a median age of about 60 years old, and the patients usually are asymptomatic at presentation, but they will have some circulating large granulocytic lymphocytes that will with an absolute value of greater than 2 × 10⁹. So these cells are actually these large granular lymphocytes are cells that have an abundant blue cytoplasm, and they have very distinct medium to large eosinophilic cytoplasmic granules. Now these larger lymphocytes are going to make up about 15% of those circulating lymphocytes. And the increase in those circulating cells can actually trigger a variant or atypical lymphocyte flag or a blast flag on your analyzer. So that's going to kind of alert you that you need to review your smear. And if there is an increased number, it will be evident on the peripheral blood smear review. And it should be reported. Most of these patients will present with neutropenia or anemia or even both. An increase in these cells on that peripheral blood can also be seen in some of your autoimmune diseases following a bone marrow transplant, or if a patient's receiving chemotherapy. So of course, doing the immunophenotyping using that WHO classification system is going to be pertinent to make this diagnosis. Now, diagnosis can be made where it is categorized into two different types of this disorder. So you can have a T cell large granular lymphocytic leukemia, or you can have a natural killer cell large granular lymphocytic leukemia. And so with both of these, of course, you're going to be looking for the particular markers. They both, you're looking for CD3, CD8, and CD57 for your T cell. And then for your natural killer cell, they're going to lack that CD3, but they do express CD56. Now, both types will have a slower progression, although your natural killer type of leukemia can actually transform into a more aggressive disorder. So now let's move on to the lymphomas. Now, even though they are centered in the extramedullary areas or outside the bone marrow, such as your lymph nodes and spleen, many forms of the lymphoma actually have a leukemic type phase. And so those are actually listed here, the ones that can actually have that phase, and they're not classified as a Hodgkin's lymphoma, but rather these are considered non-Hodgkin lymphomas. Now, some of them do have a characteristic morphology or an immunophenotype, but biopsy of the involved tissue is required in order to actually make a diagnosis. Now, if it is possible and you're able to differentiate the lymphoma type cells, you should count them separately when you're doing a manual diff. However, there may be some instances where you can't do that, or maybe your facility does not quantitate them individually. So if you suspect that these cells are present, then you need to morphologically differentiate them from normal lymphocytes, and then just kind of make a separate note that these cells are present. Adult T-cell leukemia, lymphoma, is a postthymic neoplastic disorder of the T cells that's actually associated with a retroviral infection by human T lymphotrophic virus type 1, or HTLV type 1. Now, this is a disease that's endemic in Japan, the Caribbean islands, Africa, South America, Middle East, and Northern Oceania. I will make a side note that this is something that is tested for if a patient donates blood. They do check for HTLV type 1 just to make sure that it is not transmitted via transfusion, because this virus can be transmitted via placenta circulation, breastfeeding, blood transfusion, sexual contact. So they always want to screen these units to try to prevent those abnormal cells from being transfused. Now, the risk of actually developing an adult T-cell leukemia or lymphoma just because you've had this infection or you are carrying this infection is approximately 2.5% for women, 5% for men, over a latency period of about 55 to 70 years. It does have an aggressive clinical course that's marked by extensive extranodular involvement of the peripheral blood as well as the skin. Complications of tumor involvement include osteolytic lesions, hypercalcemia, profound immunosuppression resulting in an actual infection. And of course, these complications can actually give rise to the morbidity and mortality of this disease. Morphologically, this disease is marked by an increase of the white blood cell count when there is a leukemic type phase of this disorder, and those malignant cells will actually demonstrate a very characteristic morphology. These cells are medium to large in size, and they have a very weird look to the nucleus. It's kind of convoluted, coarsely clumped chromatin, deeply basophilic cytoplasm, and these cells are often referred to as a flower cell because of its morphology. So you can see that it has a very distinct appearance to that nucleus, where it almost kind of resembles a weird little flower pattern. Not all of these cells have this distinctive appearance. So they can resemble some of the other cells that we've talked about or that we're going to talk about. So that's why it's very important to be sure that you have other means to be able to diagnose this disease. The adult T-cell leukemia lymphoma immunophenotype is generally consistent with the T helper cells. So you'll see CD3 and CD4 being expressed, where CD7 and CD8 are actually absent. CD25 and CCR4 are also highly expressed. And interleukin 2 can also be used as a marker for assessing the disease status. Burkitt's lymphoma, leukemia, is an aggressive cancer of the B cells, which is associated with a filament of clinical presentation or a rapid progressive onset. Burkitt's lymphoma actually has 3 subtypes. It has an endemic subtype. Now this form is found primarily in childhood, and it's seen in Africa along with geographical distributions that is similar to malaria. It has an extramedullary involvement, and so what you can actually see is a manifestation in the orbits or the mandible as a typical site of disease. So there's an example here where you can see around that neck or mandible jawline area where this child has a lot of those cells that has a lot of those neoplastic cells, so you see that swelling. Now, one thing to note with this particular subtype is that the Epstein-Barr virus has been shown to be present in these cells, so there is some linkage there between the Epstein-Barr virus actually contributing to this particular neoplasm. The sporadic form presents as an abdominal disease. Extranodular involvement is not uncommon. The bone marrow and the central nervous system are involved in approximately 70% and 33% of these cases, respectively. And the last subtype, HIV associated, of course, is associated with a profound immunosuppression. The blood and the bone marrow are the primary sites of this disease. Now, morphologically, there is a leukemic type of a phase that develops in a subset of these patients. And with that, you can actually see some circulating Burkitt cells that will have a very characteristic morphology. Now, these cells are medium to large in size, finely clumped chromatin, and they have a deeply basophilic cytoplasm that will actually have some very distinct vacuoles. Now, in your bone marrow biopsy, it's going to look like sheets of infiltrating medium-sized cells with a skinked cytoplasm. Now, both the bone marrow and the lymph node biopsies can show a very classic starry sky appearance, which results from the intradispersed tangible body macrophages that are suspended in a sea of malignant cells. So you can see here in this image where you just have a bunch of malignant cells, but then you have some normal appearing cells that are typical for bone marrow that may be distributed throughout that slide. Now, when testing the immunophenotypical profile for Burkitt's lymphoma or leukemia, we're looking for those mature B cells. Both surface immunoglobulins and light chain restrictions are present. The expression of CD10 and the absence of immature markers such as CD34 or TDT. Specimens that are sent to the lab for flow cytometry analysis need to be processed quickly because the high cell turnover that is characteristic with this neoplasm can result in a poor viability, and it actually can reduce the quality of those results. Follicular lymphomas represent a neoplastic disorder of the germinal B cells, and it accounts for approximately 12% of the non-Hodgkin's lymphoma cases. It is generally a disease of the middle to older age groups, and although a follicular lymphoma typically has a very slow course of progression, It is most often incurable with the current therapies that are available now. So basically, the clinical pattern of this disease progression is going to be one of a serial response to chemotherapy. So you'll actually see the patient improve with chemotherapy, and then they'll start to have a relapse. So you'll just see this cycle over and over of going into a state of remission, back to a relapse, and then eventually it results in death. Patients will usually present with some sort of painless lymphoadenopathy, but otherwise they're asymptomatic. There can be peripheral blood involvement in about 10% of cases. And with this, you're going to see those follicular lymphoma cells actually circulating, and they will actually have a condensed chromatin pattern and a very distinct nuclear cleft within those cells. And so you can see that here where you've got some cell, this one cell here, where you can see it kind of indented on both sides. For your bone marrow biopsies, you will see those tumor cells present in a specific area of that particular bone marrow. Tissue secretions, you can see those cells, but they will appear small and irregular. When we look at this disorder from a histological standpoint, it is graded according to the number of those larger malignant cells that are present. And then that grading actually correlates with the clinical outcome, with a grade 3 having the poorest outcome. Mantle cell lymphoma constitutes approximately 3 to 6% of the non-Hodgkin lymphoma cases. The median age for diagnosis is about 68 years of age, and males are affected more than females. It is considered a clinically aggressive disorder, although there are some types that there is a slow progression that has been described. Most patients will present with an extensive lymphoadenopathy. Extranodal disease is not uncommon, with the GI tract acting as a primary area of involvement. Patients that have an indolent or less aggressive form tend to have a disease that's restricted to the blood, bone marrow, and spleen. Those mantle cells can be present within the peripheral blood, but they can vary morphologically, which can actually complicate the diagnosis of this disease. So there are different forms of it, so those forms can be mistaken for some of the other lymphomas that we have previously discussed. So basically what you're looking for is those mantle cells. But as you can see, they do look a little, similar to what we've seen before. You see that little indentation in there in that nucleus. So in order to be sure that you can properly diagnose, again, you're going to look for some of those abnormalities, doing something like FISH testing, looking for some of those translocations of some of those genes and whatnot. Diffuse large B-cell lymphoma is the most common form of a non-Hodgkin's lymphoma, and it represents about 25 to 30% of all cases. It's generally a disease of the elderly, but you can see it in younger patients. It can arise on its own or as a result of a transformation from one of the less aggressive forms of lymphoma. Although it has an aggressive clinical course, it's often curable with a combination of chemotherapies. A number of the subgroups are based on morphological and genetic criteria. Now, the most common clinical presentation is going to be a rapidly expanding painless lymphoadenopathy in one or more sites, where you can see extranodal involvement within the GI tract, testes, or the bone. Now, of course, clinical symptoms are going to be dependent based off of the area of involvement. Bone marrow is affected in about 30% of the patients, and a third of those will actually exhibit some of those circulating malignant cells, which can appear as a highly pleomorphic cell with very large nucleus and nucleoli, and it can actually resemble a leukemic blast type cell. So you can see an example here where it's a very large cell. So if I saw something like this, I would probably question it, thinking that it's a blast. So from that point, I would refer it to pathology because, again, this is above our pay grade. From there, it would require some sort of immunohistochemical type of testing or genetic testing in order to rule out other lymphoid neoplasms and to actually confirm this diagnosis. Marginal zone lymphoma is a lesser, not as progressive B-cell lymphoma that typically is associated with chronic antigen stimulation, either in the setting of infection or autoimmunity. There are 3 subtypes of this lymphoma. Extranodular marginal zone lymphoma of mucosa-associated lymphoid tissue, or MALT, is these are the most common of the subtypes, and they're usually associated with organs that seemingly lack obvious lymphoid type tissue. And so what has happened is these organs have been subject to some sort of chronic inflammation. And so what will in turn happen is that it increases that B cell proliferation, and then you have errors during the class switching, and you have some sort of hypermutation that leads to uncontrolled growth and essentially some sort of malignant transformation. Now, an example of where we can see this happen would be with like an infection of Helicobacter pylori or H. pylori, which we know to cause within the stomach, lining of the stomach, it can actually cause ulcers, which can in turn lead to cancer. And generally, you can kind of see, a lot of these disorders are very similar in the fact that if there's some sort of infection, that infection can in turn alter the genetic makeup of those cells, and then that ultimately can lead to those cells replicating with that error inside of it, and so you'll just have an abundance of those abnormal cells. So obviously treating the underlying condition will help with these mutations. With splenic marginal zone lymphomas, this will actually include the white pulp of the spleen, the splenic lymph nodes, bone marrow, and very often the peripheral blood. So patients with this particular disorder will present with a massive splenomegaly and absolute lymphocytosis in the peripheral blood, and it is characterized by lymphocytes that are very similar to those that are seen in CLL patients. Mycosis fungoides and Sézary syndrome are the most familiar forms of the cutaneous T-cell lymphomas. Both are diseases of the elderly with a slight male predominance. Mycosis fungoides is the most common disorder, making up approximately 60 to 70% of the cutaneous T-cell lymphoma cases, with largely being confined to the skin, although within the later stages of the disease, you can see a dissemination to the lymph nodes, organs, and the blood. And it generally has a very slow progression. Sézary syndrome is defined as a systemic disorder with peripheral blood involvement, and it actually has a worse prognosis than the mycosis fungoides. Now, both of these are disorders of the CD4 positive T cells. What we see with the malignant T cells in both of these is that they have a very abnormal appearance with a scant cytoplasm, and they have the cerebral form of a nucleus or a folded nucleus, which demonstrates a variable condensed chromatin with some very inconspicuous nucleoli. So what you actually see is where it kind of creates all these little indentions where it kind of folds over a little bit. It actually kind of gets a brain-like look to it. So you can kind of see where right here you've got like a little bit of indention, some more indentions where you can kind of see where this nucleus is just kind of folding back over itself, where you've got all these different little entities into it, just like you would kind of like with that brain pattern. Now, to make a diagnosis for mycosis fungoides in the early stages, it can be very problematic. These patients will actually present with a psoriatic-like skin lesion that requires biopsies in order to make a definitive diagnosis. And with this biopsy, they're basically just looking for a characteristic presentation of those cells. Serge syndrome is characterized by erythrodermia, generalized lymphoadenopathy, and the presence of those T cells within the skin, the lymph nodes, and the peripheral blood. Now, in order to make a diagnosis of Serge cell or Serge syndrome, then you actually have to have a presence of Serge cells of greater than 1 times 10 to the 9th for the absolute value. So some places may actually require you to categorize those separately. Anaplastic large cell lymphoma is a T cell disorder that's associated with large pleomorphic cells. However, there is a heterogeneity to the morphological appearance in which some of these cells are actually small to medium in size. The tumors do express CD30, and the disease can be divided into 2 subtypes, and this is going to be dependent on the expression of the anaplastic lymphoma kinase protein, or the ALK protein. The ALK positive tumors generally tend to be seen in the younger populations, and they have a better prognosis overall. And they constitute approximately 10 to 30% of the childhood lymphomas. The ALK negative forms are more common in the older adults with a median age of about 57 years of age, and this subtype has been associated with breast implants. Clinical presentation for both forms is very similar. Most of the patients will present with an advanced stage of the disease, so stages 3 and 4, and with B symptoms. Anaplastic large cell lymphoma does involve both the lymph nodes and the extranodule sites, such as the skin, the bones, and soft tissue like your liver and lungs. There is a cutaneous variant in which the disease is localized only to the skin. The bone marrow is involved in about 10 to 30% of cases, which can be a very subtle disease, and the immunohistochemical stains are actually required in order to detect this form of the disease. And there are some rare cases that have been reported to have actually progressed to a leukemic type of a phase. Peripheral T-cell lymphoma, not otherwise specified, is a heterogeneous group of disorders of post-thymic T cells with rearrangement of the T cell receptors that lack defining features that would place them in another category. Now, immunophenotypically, the abnormal cells are characterized by T-cell antigen mismatch with the absence of CD7 and CD5 expression. Now, there has been deregulation of genes associated with proliferation, apoptosis, and cell adhesion consistent with an activated T-cell state that has also been noted. Now, generally, these patients will present with a disseminated disease and a poor performance status. About 50 to 70% of these cases have an intermediate to high risk score. There's often a diffuse nodule involvement with an extranodule spread to the skin and the GI tract. The bone marrow has also been involved in about 20 to 30% of these patients. Eosinophilia, in addition to anemia and thrombocytopenia, have also been seen in a subset of these patients. The plasma cell neoplasms are malignant disorders of the terminally differentiated B cells. So this is actually going to be your plasma cells. Although they constitute approximately 1 to 2% of the cancers, they are the second most common hematological malignancy. Now, they encompass a wide spectrum of disease states ranging from some relatively benign conditions. An example of this would be like the monoclonal gammanopathy of undetermined significance, or they could present with only like a presence of a paraprotein, and so this would be like a clinically aggressive plasma cell leukemia in which the tumor infiltration and the paraprotein excess can actually produce systemic complications that will result in a significant morbidity or death of that patient. Monoclonal gammonopathy of undetermined significance is actually a benign monoclonal proliferation of the plasma cells that's usually considered a plasma cell neoplasm because it represents a precursor state for myeloma. Now, although the conversion to an overt myeloma is relatively low overall, there is a subset of patients that will actually have adverse risk factors, and they have a greater than 60% chance of progression over a period of about 20 years. Now, for cases of monoclonal gammonopathy of undetermined significance, the level of the actual monoclonal immunoglobulin, or an M spike, can actually help to predict the risk for transformation to a multiple myeloma or some other type of plasma cell neoplasm. So really, in order to make a diagnosis of this disease, the patient is required to present with a serum monoclonal proteins with a non-IgM that is less than 3 grams per deciliter, or the absence of end organ damage. Now, multiple myeloma, which was once referred to as a plasma cell myeloma, it's generally a disease of the elderly with a median age of about 69 years old. Less than 2% of the patients diagnosed with this disease are younger than 40. Multiple myeloma is slightly more common in males than females, and in the U.S., the incidence is higher in the African American population than it is in the Caucasian population. It is a bone marrow-based disease, but it actually does have an extramedullary extension to the bone and soft tissue. There is some strict criteria that must be followed to make the diagnosis for multiple myeloma, and it is based off of the overall tumor burden, which is reflected by the percentage of plasma cells that's actually in the bone marrow, and the extent of systemic manifestations of the disease, such as if it's causing something like hypercalcemia, renal failure, anemia, or some sort of osteolytic lesions. Now, because it can spread to the bone, and this isn't a very uncommon finding, it may be necessary to actually do some sort of imaging studies of the skeleton, pelvis, spine, as part of the standard diagnosis, just to look to see if there's any sort of spread outside of the bone marrow itself. And it also helps with anticipating any sort of complications that can happen, like spinal cord compressions or fractures. So it can help with determining if we need to do anything prophylactically. Now, plasma cells do have the ability to secrete monoclonal immunoglobulins, whether they're whole or just a partial of that immunoglobulin, but it is an essential characteristic of the plasma cell neoplasms. However, there is a non-secretory form of multiple myeloma, and it makes up less than 1% of these cases. Now, the monoclonal immunoglobulins in these patients can actually have a negative effect across multiple organ systems, and so then they can be responsible for the morbidity that we can actually see in some of the more advanced forms of multiple myeloma. Now, with disease progression, you're actually looking for a rise in those circulating plasma cells of about 20% or more than 2 times 10 to the 9th per liter. Now, the plasma cell leukemia is a separate entity. Both forms are associated with a dismal prognosis. In other words, it's not a good outcome, really. So one of the things that we do tend to see as this disease progresses in those proteins, you start getting more of those abnormal proteins, then you can actually start seeing what we call rouleau. And so rouleau is where you actually see those red cells kind of stacked together in that little caterpillar type of formation, or where it kind of looks like a row of stacked coins. So this can actually interfere with your testing in various departments when you actually have rouleau present. Now, when making a diagnosis, you would note that these patients express high levels of CD38 and CD138, low levels of cell surface pan-leukocyte marker CD45, and they can express the natural killer cell associated marker CD56. Waldenstrom's macroglobulinemia. So this is a low-grade lymphoplasmatic lymphoma that is a heavy chain disease, and it's characterized by discrete secretory products. So you actually see high levels of IgM that will result in a hyperviscosity syndrome. Now, because of this syndrome, there may be the need for an emergency plasmapheresis to actually alleviate some of those symptoms. There can be an extramedullary involvement that will include a nodule disease and hepatosplenomegaly. Now, with this disease, there's going to be a distinct somatic mutation in the myeloid differentiation factor 88 or MYD88 gene. And so this is found in actually about 90% or more of patients that have this disease. And it is a molecular marker for the disease, and it can differentiate it from other lymphomas that can look very similar morphologically when you're actually looking at those plasmacytic differentiation. Now, the symptoms are going to be dependent on that heavy chain involvement, but just like within multiple myeloma, that paraprotein can actually cause significant damage to the organs such as kidney or the liver. Hodgkin's lymphoma is primarily a lymph node-based disease with about 2.7 cases per 100,000 persons per year within the U.S., and it's generally a disease of young adults. Now, morphology is going to be used to actually make a diagnosis, and this is going to be based off a lymph node biopsy. So there are two forms that we typically will see and are going to discuss, which are going to include classic Hodgkin lymphoma and then the lymphocytic predominant Hodgkin lymphoma. With classic Hodgkin lymphoma, what we're looking for is the Reed-Steinberg cells or the Reed-Steinberg-like cells to be present. There are 4 histological subtypes to this disorder. There is a bimodal age distribution with peaks at about 30 years of age, but then you can also see a peak again about age 50. And it can also present with the cervical, supraclavicle, and mediastinal adenopathy, and it can spread in a contagious type manner. Now, the lymphocytic predominant Hodgkin lymphoma will actually present with a lymphocytic histiocyte. And with this disease, it is a disease of young adults. It presents with peripheral lymphadenopathy, but the mediastinal adenopathy is rare, and nodule involvement is not contagious, and the extranodule involvement is rare. So both forms can be accompanied by your actual B-cell symptoms. Treatment is going to be based off of the staging criteria. So here we're just going to kind of differentiate the morphology between these two cells. Now again, note that these are going to be seen when the lymph node biopsy is done. Now with classic Hodgkin's lymphoma, when you're looking at these Reed-Steinberg cells, they almost are never found in peripheral blood smear, but you can occasionally, a rarity, see these. So that's why we're going to kind of cover what they look like. So your Reed-Steinberg cells are of B-cell origin, although they do like most of your B-cell markers, and they are binucleated or multinucleated with an abundant cytoplasm and distinct nucleoli. So you can see down here where you got these classic, the classic kind of presentation of these cells. You can see down here where you've kind of got 2 nucleoli or 2 nucleus. It may be dividing there, or that may be a separate cell. It's kind of hard to see. Again, you can have some variations to these cells based off of the subtypes. They are positive for CD30 and often co-express CD15. The variants reside in the lymph nodes in a sea of reactive cells. So these reactive cells could be anything like lymphs, eos, granulocytes, histocytes, plasma cells. So again, in those lymph nodes, you're just going to see a sea of reactive cells is basically what you're going to see. Now, the lymphocytic histocyte cell or histocytic cell, they too B cell origin. They are large with a very scant cytoplasm and a folded single nucleus. So you don't have binucleated or multinucleated. It's actually just kind of folded over itself. These are referred to as popcorn cells. They are negative for CD15 and CD30. So whereas your other cells are positive, these are negative. About 50% will express an epithelial membrane antigen, and they exist in a nodular background composed primarily of small lymphocytes. So whereas you can see a variety of cells for the Reed-Sternberg, you can, with this particular one, you're just going to see those small lymphocytes. So you can see here where you've got the popcorn cell. In this image here, you can see that nucleus kind of got the weird look to it versus your Reed-Sternberg cells.